Like, this is another interesting topic, uh, which has very limited text description in both slides and JIR, and literally no or limited description in DDCEP, which are core curriculum. So most of this uh, data for SCAD is something which I took from PubMed. And in fact, when you do a PubMed search with segmental colitis associated diverticulosis, there are 52 articles, 52 or 72 articles, with 10 to 15 of them as case report, and 10 to 15 of them as isolated studies, and 10 to 15 as biological therapy. So there's very minimal real studies on this segmental colitis associated diverticulosis topic. So I'm going to go a brief review of diverticulosis in the interest of time. So it was described in 1849, and the first resection of diverticulitis was performed in 1907, almost 100 years ago. And then the term was coined by a radiologist in case series. And then if you look into, there's interesting demographic profile, with the West having left-sided diverticulosis, and Asians and Middle Eastern having right-sided diverticulosis, and they favor that the left-sided have, it's definitely related to dietary and epidemiological factor, because the autopsy performed in previous century has minimal diverticulosis, and with the evidence of fast food and low fiber in the diet, the diverticulosis is included in the left side. Okay. So these are the areas where the diverticulus happens. So this is a false diverticular because only mucosa and submucosa are involved, not the all layers involved. There are three tenei, two antimesenteric and one mesenteric tenei. The two antimesenteric tenei, the diverticular pouching happens not randomly. It's generally on one of these four areas, which are either flanked by two mesenteric tenei or two antimesenteric tenei, and this is where the vasa recta penetrates, and that's where one of the possible postulated hypotheses, there is weakening of the mucosa layer. So in the spectrum of diverticulosis, we have asymptomatic diverticulosis and symptomatic diverticulosis. This is 80%. This is around 80 to 85%. This is around 15 to 20%. Now, out of them, majority of them are SUD, which is patient have just abdominal pain but no radiological or endoscopic evidence of inflammation. They have abdominal pain, that's it. This contributes to 10 to 15%. This happened again to 5 to 10%, which is diverticulitis. Now again, we know diverticulitis can be uncomplicated and complicated. Complicated is defined by obstruction, fistula, perforation, or abscess. And then there is diverticular bleed, which is 5%, and then there is segmental colitis associated diverticulosis, which is less than 1%. So this is very uncommon, and something which is also a matter of research over the last couple of decades. It's newly recognized entity. So it's also known as diverticular colitis. And interestingly, what happens is the diverticula itself is not the diverticula itself is not involved for the inflammation. The adjacent peridiverticular area has inflammation. The histology is just, I'm going to go over the histology, just forget it, because there are four types of SCADs described in the literature. These are the isolated case reports. The first one was published in 1983, and you can see that majority of them were a couple of patients and describing they did mesalamine, they did steroid enemas, and all that stuff. Okay, so the prevalence is about 1%, and it's higher in men and at older age. So old men have SCAD. What's the pathology? So when you develop diverticular disease, you can have mucosal prolapse due to fecal stasis, which causes dysbiosis, and then increase antigen exposure and eventually inflammation, and then you can develop different kind of SCADs. And I'm going to go over what are the different kind of SCADs. So interestingly, you have to make, generally this is diverticular. If there is inflammation present here, this is likely diverticulitis. And if there is inflammation in the normal intervening mucosa, then you have to consider IBD as a potential diagnosis. And limitation of this thing is, with IBD you have characteristic, you can have some changes, and also you can have other area of pattern of enablement which discriminates SCADs from IBD. And this is a matter of debate. Some people think SCAD is a precursor of IBD. Some people think that SCAD and IBD are very correlated. Older people present IBD with SCAD first and then going to IBD. So these are the kind of studies which have been published lately. So what do the patient present with? Some abdominal pain and cramping. Who texted me? Okay. Okay. Imaging findings. You can have just colonic wall thickening in the area of diverticulosis. Laboratory findings are non-specific. Just because there's inflammation, you might find some lactoferrin and calprotectin elevation, but it's not something very specific. So the first description and a good study regarding describing the SCAD was done in Italy, and what they described was the four pattern of SCAD: the crescentric pattern where there is just mild inflammation, and it resembles something like acute colitis, no IBD feature. Type B and D pattern have very similar to ulcerative colitis pattern, and type C is Crohn colitis pattern. I'm going to go see the picture. So this is type A pattern, which is called crescentric pattern. So this is the diverticula, and the nearest crescentric pattern, they have mild inflammation around over here. And this is generally, isolated red patch, 1 centimeter in diameter, nothing crazy about this thing. And the pattern is very similar to, neutrophilic infiltrate. So any acute colitis would present like this thing. And this is the most common pattern present in 50 to 60% of the individual. And here you can see that there could be some crypt abscesses, neutrophilic infiltration, but there is no crypt distortion over here. So this is what distinguished this pattern from other pattern. Now here you can see there's a loss of vascular marking, ulceration, friability, crypt abscesses. So these are ulcerative colitis like pattern. And one of the postulated hypotheses is in older age, this could be a precursor for UC. Again, more studies are needed. And here there's a crypt distortion, there's an abscess formation. Now, other spectrum is Ephth's ulcer, and sometimes these ulcers can also have granuloma, and this is called Crohn's disease pattern. This is type C pattern. And the last pattern described is very, very severe ulcerative colitis like pattern. Here you can see that just bad looking colon in the sigmoid area with intense infiltrate, lot of crypt abscesses, and diffuse neutrophil all over the sigmoid colon area, and clearly this was calling for a therapy, and a lot of time these people sometimes required resection. Actually, we have this patient, I don't know whether Dr. Win is over here, a couple of days ago. He was an 80-year-old guy presented with this pattern, and in fact the biopsy shows IBD. So, and this is a matter of debate: should we treat them as an IBD or should we treat them with antibiotics? Because this was his third episode, and both the time he got ciprofloxacin and fragile, and his symptom responded. It lasted for a couple of months, then he had a repeat attack. He saw three doctors. One at Louis Gale, went over here, and one at UNC. So now he's a VA patient. So Dr. Sagir is thinking of starting him on one of the biologics. And interestingly, you will find that these patients who are older and they have divert SCAD, they or IBD, old IBD, they have poor response to anti-TNF therapy, and this calls for the fact that is it really IBD or is it really SCAD, which have more response to antibiotics than to anti-TNF therapy. Something which is another matter of research. Okay, so endoscopic patterns and symptoms are more with diarrhea, abdominal pain, rectal, and you can imagine the D, which is the bad part, has more abdominal pain and associated with rectal bleeding and obstructive symptoms. So you will differentiate with IBD. There is more pattern, different areas of involvement. Medication, there would be history of medication, infectious, you'll check stool culture, then you can solitary rectal ulcer syndrome, there's hypertrophy and replacement of lamina propria with fibrosis. So these are one of the differentials, and radiation colitis. Nothing specific or interesting about over here. And so management, so as I described, there are only 52 articles published related to SCAD in PubMed, and most of this experience is anecdotal, and there's no randomized control trial. The highest evidence is antibiotics, Ciprofloxacin flagell, and this patient, which we saw a couple of weeks ago, this was his third relapse, and he just did very well on Cipro and Flagyl. And if the antibiotics fail, then you can do mesalamine and it can be extended to 1 month with a double dose, and response rate is 80%. If mesalamine failed, then you can do steroids, and if steroid fail, then you can consider resection. In Europe, oral beclomethasone plus this probiotic VSL3 has been described as also a good promising response. We don't have oral beclomethasone available in the United States. So this was the therapy: first line, second line, and third line. And you can see that the first line is always antibiotic followed by mesalamine, and then second line is beclomethasone plus VSL3. Okay. Prognosis, limited study. Most of them have benign course. So this was the longest study, which is 7-year follow-up of SCAD patient. Again, 15 patient, 13 benign, and 2 developed Crohn and some disease. The author concluded this 2 patients with Crohn disease could be just a chance association, not necessarily associated with segmental colitis developing into Crohn disease. Um, uh, there's no higher, again, the mortality, majority of the patients responds to therapy with antibiotic, and those people who don't respond, sometimes they relapse, and you might have to consider long-term therapy like mesalamine and possible oral steroids along that line. So here, most of the studies, what they looked into was they looked into the fact that the patient has segmental diverticulosis, and they looked into the colitis in that. There's one study which was reversed, where they looked into the patient which has IBD, and they looked into how the patient with IBD respond, IBD with diverticulosis versus IBD without diverticulosis. So well, this was done at my residency with Dr. Korlitz, credited with starting Imuran in the United States for inflammatory bowel disease. And he and the groups shows that there is more sigmoid inflammation. The patient with IBD and diverticulosis have more sigmoid inflammation and rectum, and they have more common extraintestinal manifestation, and they are associated with older age. And that's why this disease is slightly different than just pure IBD. I think that's how I'm going to end, and these are my references and discussion. I think it's 5 o'clock.